Welcome to the first module that we have on gastroenterology, which is diarrhea. So, what exactly is diarrhea? Let's quickly get on with the very obvious definition of diarrhea. Diarrhea is nothing but stool water content being greater than 200 ml in the last 24 hours. So, this is an interesting thing. Why is the definition so interesting? Because many of us have this wrong conception about diarrhea being something having to do with the frequency of the stool excretion. That is not it. So you can have, there are people whose stool habits, it's bizarre. It is so bizarre that they have to pass stools 3 or 4 times a day. So does that mean that they are suffering from diarrhea? Not necessarily. So what exactly defines diarrhea? Diarrhea is defined by stool water content being greater than 200 ml in the last 24 hours. So this is the proper definition of diarrhea. Okay. So now, since we are talking about diarrhea, let's talk about how we classify diarrhea exactly, and why this is such an interesting disease per se to discuss from a physician's perspective. So if I'm to divide diarrhea into something, or classify diarrhea into the divisions that it is based actually on many things. So there is not one classification of diarrhea, there is classification of diarrhea based on many things. So let's first deal with, before we do that actually, let's look at something else. So we were talking about the definition of diarrhea. Based on the definition of diarrhea, we have something called the Bristol stool chart. Actually, Bristol stool chart, I know this might actually look a little strange, this might look actually a little dirty, whatever, but gross actually, but there's nothing to be grossed about. We are all in the medical field and we have to deal with stuff like this all the time. So anyways, Bristol stool chart. So Bristol stool chart, this has actually 7 types of stool. Type 1 and type 2, these deal with constipation, which is the opposite spectrum of diarrhea. Type 6 and type 7, they actually deal with diarrhea, proper diarrhea, mild and severe. Whereas the others, they are for the most part normal. Okay? So type 1 and type 2 constipation, type 6 and type 7 diarrhea, type 3, 4 and 5 for the most part normal. Okay? So now that we're talking about diarrhea, let's classify diarrhea into, what can we classify diarrhea into? First, we can classify diarrhea into acute. We can classify diarrhea into something called persistent, and we can also classify diarrhea into something called chronic. Very, very interesting. So what exactly is this classification based on? This is based on frequency. Frequency of what? Frequency not of the stools itself, but how long have the symptoms been going on? So an acute case of diarrhea is when the patient is presenting to us with a case of diarrhea which has been going on for less than 2 weeks. Chronic, like most diseases, when the case has been going on for more than 4 weeks. And 2 to 4 weeks means for the most part it is persistent. Okay. Now, one very interesting thing that you need to understand is we really, for the most part, do not take acute diarrhea as a very serious entity. I will tell you cases where we do take acute diarrhea in a very serious professional manner, where we will get actually a little concerned. But for the most part, acute diarrhea is a nuisance symptom. Okay? There are many reasons why we can have acute diarrhea, and I'll tell you what the etiology is in a second. So this is basically the classification of diarrhea based on the frequency, that is, how long the diarrhea episodes have been going on. When is the patient presenting to us? Now, let me talk a little bit about the thing that we have already started discussing, which is acute diarrhea. So, acute diarrhea, what exactly is it? Less than 2 weeks. We know this. The most common cause for acute diarrhea is infectious. And what infection? A viral one. This brings us to a very, very important information, which is what viruses are most important. The most common virus that causes diarrhea in adults is the norovirus. Norovirus in adult. Whereas the most common one in children is rotavirus, which is why we also get rotavirus vaccines in India, specifically for this reason. Okay, so this is the most important thing. And like I said, why this is a nuisance symptom? Because this is, for the most part, self-limiting. This will resolve on its own. That is the most important thing. Okay. Okay. So if I think of acute diarrhea, for the most part, I'll think that this is a viral infection. Done. Although we will see that acute diarrhea can also be caused by other symptoms as well, other infectious organisms as well. What are they? What can they be? Bacteria. Can bacteria cause acute diarrhea? Yes, bacteria can cause acute diarrhea. And what bacteria cause acute diarrhea? We will see to that when we'll classify diarrhea into another thing, into another mold. So this part I am leaving right now. Okay, acute diarrhea, for the most part right now, just remember that it is the most commonly caused by viral infections, norovirus in adults, rotavirus in children. Now let's come to chronic diarrhea. So chronic diarrhea was when we are getting episodes of diarrhea for greater than 4 weeks. When this is the case, then I will be a little concerned, because chronic diarrhea, for the most part, is caused by 3 reasons, or there are 3 differentials for this. So 3 DDs for this differential diagnosis. First is osmotic. I'll tell you what osmotic diarrhea is. Second is secretory. I'll tell you what secretory diarrhea is. And the third is inflammatory. We will come to individual topics or these individual subtopics a little later. So chronic diarrhea has 3 differential diagnoses, which is osmotic diarrhea, secretory diarrhea, and inflammatory diarrhea. These 3 can be the causes. What exactly does osmotic diarrhea mean? Osmotic diarrhea means there is some kind of a malabsorption going on in my body. What does secretory diarrhea mean? There is some kind of an infectious organism in my body which is secreting some kind of a toxin that is leading to this. And what does inflammatory diarrhea mean? It means I have some inflammatory condition, for example, inflammatory bowel disease. Okay, so let's talk about these individual diarrhea subparts in a little bit more detail. First, we have osmotic diarrhea. So what exactly is osmotic diarrhea? It's very simple actually to understand. See, normally what is happening, if this is, my esophagus, food is coming down via the gullet, then it is getting into my stomach, my duodenum, jejunum, ileum, etc., into the small intestine, whatever, going through the folds, whatever, and then it is getting into the colon over here, right? A very, very bad drawing, but whatever. So for the most part, this is what is going on. So the food is going on like this. So it's a huge, long, coiled tube that the food is going through. Normally what happens is, when the food is going through my gullet, when the food is going through my stomach, when the food is going through my small intestine, we all know that digestion occurs. At different parts, at different stages, digestion is occurring, absorption is occurring, all these things are occurring. But if there is some problem in this digestion, if the food is not being digested properly, if the food has some problem in being absorbed properly, then we get something called malabsorption. Malabsorption. Now, don't be foxed by this. Malabsorption leads, or rather, malabsorption means both maldigestion and malassimilation. Okay, so malabsorption does not only mean that my food is getting properly digested, my food is actually getting broken down properly, but it is the absorption that is defective. No, malabsorption can also mean that my digestion, where my food from its complex constituents is being broken down into its simpler counterparts, that part is also affected. That might also be something that is malabsorption. Okay, this is the most important. Malabsorption is the most important reason for something called osmotic diarrhea. Why I drew this beautiful Picasso level drawing is because if I have malabsorption, guys, think, if my food is not getting absorbed properly, then it will keep going, and it will then reach what? It will reach my large intestine, my large gut. Now, in the large gut, what is present? Different bacteria, different colonic bacteria, they are present. And what they will start to do is they will start to break down this undigested food particles. And that will produce a lot of gases, that will produce a lot of flatulence, that will produce a lot of bloating, etc., etc. Other than that, another interesting thing that happens is, because of malabsorption, this food laden substance which is rushing down my small intestine, large intestine, and through my entire digestive tract, what that will do is that will start attracting water. It will start attracting, or rather start drawing water from the surrounding cells. So what will happen is water will rush in. Okay, because why is that happening? It's very simple to understand. If the food had been digested, if the food had been absorbed properly, then obviously this would not have happened. But since the food is now still in its unbroken complex forms, it is osmotically active. So this osmotically active, we know that any liquid always has a tendency of moving from its higher concentration to its lower concentration. That is what osmosis is. If that happens to a semi-permeable membrane, then that is what osmosis is. Basically diffusion via semi-permeable membrane. Here the permeable membrane is the gut, the enterocytes. Okay, so these food substances, they're osmotically active and they will draw water from the entire GI tract. And what this will lead to is very simple. This will lead to a kind of diarrhea, which is rich in water, undigested food, nutrients, and this is what we say to be osmotic diarrhea. Osmotic diarrhea. Okay. Now, the most important nutrient that causes this osmotic diarrhea is very important. It is fat. Fat is the most calorie dense nutrient, and fat is the most osmotically active nutrient, and fat is also notoriously involved with malabsorption. Okay, so fat will actually cause malabsorption. If there is, we will see to the details of fat absorption in a later video. If there is some kind of a problem in that, there will be malabsorption syndrome. We'll talk about malabsorption syndromes in detail. So this is what osmotic diarrhea is. So how exactly are we going to? So before we go into the investigations as to how we detect malabsorption or how we detect fat, look at what is happening here. We are getting fat in our stool. What is this called? This has a special name. This special name is called steatorrhea. Steatorrhea is basically what I just explained, which is fat laden stools. Now, normally, should you have fat in your stools? No, fat is an essential nutrient. You should be absorbing them from your gut. You should be absorbing them via your small intestine. Then why is fat in your stools? It should not be there, but due to some problem, due to some malabsorption, something is going on in your gut. The fat is in your stools. That is called steatorrhea. And what is this steatorrhea causing? What is the fat in your stools doing? It is also drawing in water and it is leading to osmotic diarrhea. So, can I, friends, say that osmotic diarrhea is a very, very important clinical marker of steatorrhea? Can I say that? Yes, I can say that. Yes, I can say that. Osmotic diarrhea is a very, very important clinical sign, a very important clinical parameter of steatorrhea for detecting steatorrhea. How will you detect steatorrhea? We will see to that. But can I say that if I find a case of osmotic diarrhea, I can say that mostly that is due to steatorrhea, due to malabsorption. So malabsorption causing steatorrhea, causing osmotic diarrhea. This is something that we can all be confident about as far as our knowledge is concerned. Okay. Now, let me quickly deal with the investigations that we do for detecting fat as to, because we have to detect the fat in our stool. How can I just make a clinical diagnosis of steatorrhea? I need to actually find fat in your stools. And how do I find fat in the stools? By some tests. So, this brings us to the investigation for steatorrhea. So, what do we have here? The most important test that we have here is something called the 72-hour fecal fat test. This is a quantitative test. Quantitative. Okay. What does this mean? Very simple. It means that for 5 days, I am going to feed the patient fat laden food. Okay. Food rich in fat. I give that to the patient. Then on days 3, 4, and 5, I'm going to study the stool of the patient. If I find that the fat content is less than 7 grams per day, fat content is lesser than 7 grams per day, then that is normal. It is normal. But greater than equal to 7 grams per day or greater than 7% stool excretion, greater than equal to 7% stool excretion, then that is diagnostic of steatorrhea. Steatorrhea. This is the quantitative test, which is 72-hour fecal fat test. Okay. This is the crux of it. Now, just like we have a quantitative test, we also have a qualitative test. What is a qualitative test? The qualitative test is something called, let me first write it, qualitative test for malabsorption or for steatorrhea, whatever you want to say. That is by something called a dye. What dye? Sudan 3. Sudan 3. Now, there are other dyes as well, like Sudan 4 dye, like oil red O. These dyes are also there, but Sudan 3 is the most important one. So what is this? This is a qualitative. So this will only tell me if yes or no fat is present in my stool or not. But it won't give me the exact percentage, the exact quantity of fat. For that, I need the 72-hour fecal fat test. Done? Done. So what exactly were we discussing? Let me go back. We were discussing this, chronic diarrhea, and we just discussed osmotic diarrhea, malabsorption. Now we have to discuss secretory diarrhea. So these are all differential diagnoses for chronic diarrhea. These are all diarrheas which can be chronic. That is, they can cause episodes of diarrhea for more than 4 weeks. That is why we are chronic. Can they cause episodes for less than 2 weeks? Can it be just malabsorption and then stop suddenly? I don't think so. Because malabsorption is something which is a persistent thing. It will keep happening. So for a long time, the patient has a diarrhea. I might think that this might be malabsorption. Long time the patient is having diarrhea, chronic diarrhea, I might think that maybe this is secretory diarrhea, inflammatory diarrhea. Okay, so now let's come to the next type of chronic diarrhea, which is secretory diarrhea. So what is secretory diarrhea? What is the little thing that I told about secretory diarrhea? I said that secretory diarrhea means something is being secreted. What is being secreted? Secretory diarrhea means two things. It can either be due to toxins that are being secreted by organisms, infective organisms. What kind of infective organisms? Infective organisms can be bacteria like enterotoxigenic E. coli, like Vibrio cholerae. It can also be by viruses like rotavirus. Remember, rotavirus was a very common etiology for children associated diarrhea, acute setting. But rotavirus can also cause, because these are preformed toxins, it can also secrete toxins, and that can lead to secretory diarrhea. Okay. Another very interesting reason for secretory diarrhea can be a non-infectious cause. What non-infectious cause? That is due to tumor. Now, I won't think of tumors initially, but if I find out that if I rule out an infective pathology or an infective etiology, and I'm thinking that this might be a secretory diarrhea, then I might say that this is due to a tumor. And what tumor? VIPoma. VIPoma, we'll talk about VIPoma later in detail. VIPoma is something, it is a kind of a tumor, neuroendocrine tumor. You'll learn about it later. It is associated with a triad. What triad? The triad of WDHA. WD means watery diarrhea, which is something that we are studying over here, watery diarrhea. H means hypokalemia, and A means acidosis. It's very simple. This VIPoma, or even actually secretory diarrhea in general also, you can say, leads to hypokalemic acidosis. Why is that? Again, very simple to understand. When can you get hypokalemia? You can get hypokalemia when your potassium is decreasing, obviously, in your blood. That is the entire definition of hypokalemia. But how is the potassium in your blood decreasing? Because the potassium excretion from body by kidneys, that has increased. So potassium is being thrown out of the body. And why is that? Because these tumors, or these even the infectious organisms that are causing secretory diarrhea in this case, they are leading to toxins. They are actually forming toxins, these infective organisms, or these tumors, VIPoma. They are leading to what? They are leading to solute loss from our body via the water. That is why watery diarrhea. But water won't go alone. Water will also draw in sodium, potassium. These solutes also will lose from our body because of the watery diarrhea. So hypokalemia. And why acidosis? Acidosis is because these toxins, or whatever they are leading to what? Malabsorption, and thus there is fermentation going on. Fermentation goes on of the undigested food. Fermentation of undigested food means there will be what? Acidic environment. H plus will increase. That is why hypokalemic acidosis. This is something that is seen. But remember, very interestingly, these secretory diarrhea, it will never cause any structural damage. So the structural integrity of the small intestine, large intestine, or the entire GI tract, that will not be disturbed. Okay, only preformed toxins or the tumor that is leading to watery diarrhea. Okay. So now we have two entities with us. What are they? Osmotic diarrhea and secretory diarrhea. So how exactly do we differentiate between them? This is an interesting thing, an interesting exercise. Let's do it. So osmotic diarrhea and we have our secretory diarrhea. So for understanding the differences between osmotic diarrhea and secretory diarrhea, I need to explain to you something called the stool osmotic gap. Okay, let me first explain to you what stool osmotic gap means. Stool osmotic gap, don't worry, it's very, very pertinent to our discussion. Stool osmotic gap. What is it? It is nothing but the measured osmolality of what? Of the stool minus the calculated osmolality. Okay? Both of the stool, of stool. So what does this mean? This means that I have the stool, I measure the osmolality of it. It should be around, for the most part, it is around 290 to 300. This is the measured osmolality of stool. Okay. Minus, I am subtracting this, or rather, I'm going to subtract something from this. What is that? Calculated osmolality. This calculated osmolality is, we have a formula for this. 2 multiplied by the concentration of stool sodium plus stool potassium. 2 multiplied by that is the calculated osmolality of the stool. This is the stool osmotic gap. Now understand what is happening over here. This measured osmolality of stool normally is 290 to 300. And the calculated osmolality of stool is something that I am getting. This is something, measured osmolality of stool, and this is something that we are calculating. So this is normally 50 to 100 milliosmol per kg. 50 to 100 milliosmol per kg. Now when I explain to you the individual diarrhea causes and their correlation to stool osmotic gap, everything will become clear. Don't worry if you haven't completely understood what stool osmotic gap is. Let's go back to our table on osmotic diarrhea and secretory diarrhea. Osmotic diarrhea, what was happening to what exactly was the pathology in osmotic diarrhea? That unabsorbed nutrients, fat, steatorrhea, water was being drawn in. So what do you think will happen to the measured osmolality? Come over here. The measured osmolality of stool, what will happen to that? I have a lot of fat. I have a lot of fat in my stool right now. So that means that the osmolality of the stool is high. So the measured osmolality is high. That means measured osmolality of the stool being high minus the calculated osmolality of stool, what will the difference be, more or less? If this increases, if this thing increases, obviously this will increase as well. So that is why stool osmotic gap is increased. It is greater than 100 milliosmoles per kg. But what happens in secretory diarrhea? In secretory diarrhea, do we have lot of nutrients which can increase the stool osmolality? No. It is mostly watery, right? In fact, we have some sodium, potassium, etc. in our stool, right? So that is why the calculated osmolality of the stool, which was 2 multiplied by stool sodium plus potassium, this will be increased because now I have more stool sodium and potassium in secretory area because of the pathogenesis we just saw. So in this, the stool osmotic gap is decreased. Or it can be normal as well, no hard and fast rule. But it is definitely 50 or less than 50. Okay. Now, another very, very important and pertinent thing. What is the response to fasting? Very simple correlation, common sense. If I don't eat food, I don't eat fat, I don't have fat to malabsorb, the diarrhea that I was having due to malabsorption of fat ceases. So I have improvement of my symptoms in osmotic diarrhea when I fast. But I fast, I don't fast, the infectious organisms or the tumor in my body does not care. So it will continue to secrete its toxins. So response to fasting, no change. Now, another thing that I said, what happens to the stool pH? Because of the unabsorbed carbs, unabsorbed fat, whatever, steatorrhea, all of this, what is happening? Large gut has a lot of these bacteria, which are colonic bacteria. And what will they do? They will start fermenting the unabsorbed nutrients that I have in my stool. And what will that lead to? Fermentation. Fermentation will lead to stool pH being less. It is acidic. How acidic? Less than 5.5. Whereas in this case, it is greater than 6.0. Here also some fermentation happens. That is why I said that acidosis here also we'll see, but it is not as bad as osmotic diarrhea. Okay. So this is more or less the differences between osmotic diarrhea and secretory diarrhea. Very, very interesting differential diagnosis for chronic diarrhea causes. Now, another very interesting diarrhea cause that we have, and this is something that is very interesting, is something called factitious diarrhea. Factitious diarrhea. So what exactly is factitious diarrhea? Very interesting. What happens is, suppose I'm seeing an adolescent female. She's suffering from chronic diarrhea. She's also having fatigue, weight loss, etc. Okay. So she's having this chronic diarrhea for greater than 4 weeks. She comes to my clinical practice. So what I do, obviously I have to see the stool osmotic gap. So I order a stool osmotic gap. Now, what will happen to the stool osmotic gap? Let's see. Or rather, let's see what we found out. This is very, very, very interesting case. See, the stool osmolality initially, just the stool osmolality, I'm not even talking about the stool osmotic gap, just the calculated, just this thing. Where is it? Where did I write? Oh, here. Sorry. Where did I write the factitious? Oh, over here. Okay. So see this thing, the measured osmolality of the stool. This is what I'm talking about. I'm not even talking about the stool osmotic gap. Not even talking about the gap. I'm just talking about the osmolality of the stool that I'm measuring. That was found out to be very low. Very low. Like approximately like 20 milliosmol per kg. Now remember what the normal range was? The normal range was 290 to 300. You have a female, adolescent female, chronic diarrhea with this low a stool osmolality. Is it possible? What is happening? How is she even alive? Right? A stool osmolality this low means she's basically excreting only water. Right? So this was when she was asked to collect her own stool sample. Now, when she is collecting stool sample under supervision, what happens is then the stool osmolality comes to be normal, which is close to 279, 280, like that. So what is this? This is factitious diarrhea, means she was making it up. That is what this is. So basically, when she was unsupervised, she was adding water to her own stool. She might also add some other solution to her own stool, and I am saying she to hammer into you that this factitious diarrhea is more commonly seen in adolescent females. Okay, so often we have, in childhood, I think diarrhea and abdominal pain was the leading cause for not going to school, for missing school. Or rather, let me reframe it. Making up an episode of diarrhea, making up abdominal pain, that was the best way of bunking school. So this is kind of like that. As adults also we do it sometimes. I'm not feeling well. Why? My, tummy is hurting, aching. Mama, my tummy is aching. Kind of like that. Now, children obviously won't come up with such hurdles as to add water to their stools and do all this. But adolescent females, factitious diarrhea case, they might do it. So, to mimic that, so when you are adding water to your stools, obviously the osmolality will go down a lot. That is what was happening. So this is factitious diarrhea. It's not exactly a disease per se. It is more of a, you have to catch it. The patient might be lying to you. That kind of a thing. Okay. So we studied about acute diarrhea. We studied about chronic diarrhea. We studied about osmotic diarrhea. We studied about secretory diarrhea. Now, let's classify diarrhea into another interesting way. What is that? That interesting way is the anatomical classification. Anatomical classification. Anatomical classification of what? Of diarrhea. How is that possible? Diarrhea is a disease. How can you anatomically classify it? That means that I am classifying the diarrhea that we are getting as a clinical presentation based on what organ, which part of the gut is affected. Whether it is my small intestine or is it my large intestine. So I have two kinds of diarrhea: small intestine diarrhea and large intestine diarrhea. What are these? Let's see. There are some differences between small intestine diarrhea and large intestine diarrhea. What are they? Let's quickly see. First comes the point of etiology. What do I mean by that? Etiology means that, okay, let's make this something else. Etiology. Etiology, as far as etiology is concerned, etiology means what kind of a diarrhea is a small intestine diarrhea. Mostly it can be an osmotic diarrhea. It can be a secretory diarrhea. Okay. So let me draw a line over here like this. So it can be an osmotic diarrhea, it can be secretory diarrhea. And we have seen the etiologies. We have seen what osmotic diarrhea is. We have seen to some extent what secretory diarrhea is. Large intestine, on the other hand, always remember that as far as the etiology is concerned, it is always some kind of an invasive organism. Always some kind of an invasive organism. Let me rub this quickly. Right. Clear, distinct boundary. Osmotic, and we have secretory. So what does this mean? This means infective invasive organisms like example, Shigella. Now this is more the microbiology domain, we know that, but infective invasive organisms like Shigella, and another etiology is inflammation. Inflammation like ulcerative colitis. Ulcerative colitis. What is ulcerative colitis? Do not worry. We will have an entire video discussing inflammatory bowel diseases. There we will learn in detail what ulcerative colitis, what Crohn's disease, these things are. But remember for now that inflammatory conditions like ulcerative colitis, mainly the kind of diarrhea that they cause is large intestinal diarrhea, whereas infective can be both large intestine as well as small intestine, because secretory diarrhea also means that there is some kind of an infection. But secretory diarrhea is more due to toxins which have already been formed being released by these organisms, and not by these organisms actually perforating the gut wall, invading the gut wall and moving in, which happens in infective invasive organisms like Shigella, causing large intestine diarrhea. These small intestine diarrhea, they are pre-formed toxins causing secretory diarrhea like enterotoxigenic E. coli, Vibrio cholerae, these things. Okay. Now, next point. Let's quickly move on to the next point. Let's draw a line over here. Second point. Second point is the clinical presentation. This is small intestine. This is large intestine. Small intestine clinical presentation, as far as the diarrhea is concerned, it is watery, large volumes, watery, and most importantly, very, very important, the frequency is less, urgency is less, there is no tenesmus, no abdominal pain, very, very importantly, no blood, no mucus in the stool. Very, 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 this is the most important point. If you do not remember anything as far as the differentiating points are concerned between small intestine and large intestine diarrhea, you don't need to worry about anything. Just worry about this one thing. Just keep in your mind this one point, that clinical presentation, if you find blood, mucus in the stool, if you find that the patient is having very, very strong abdominal pain, there's a lot of discomfort in the patient, tenesmus is there, frequency is high, urgency, that is urge to go to the bathroom, urge to pass stools is very high, then that mostly is large intestinal diarrhea, because in small intestinal diarrhea, the stools are watery, large volume stools. Because we saw that osmotic diarrhea is a presentation of small intestinal diarrhea, and osmotic diarrhea is steatorrhea, we saw that. So just the opposite of this will be the large intestinal diarrhea, which is that the stool will be small volumes, and the frequency will be high, urgency will be there, tenesmus will be there, abdominal pain will be there, blood, mucus, these things can also be there in the stool. Very, very, very important. Okay, just like that, abdominal cramps. This is another thing. Abdominal cramps, now this is an interesting thing. Abdominal cramps can be present in both. Why is that? Because abdominal cramps is something that you're getting for what? Abdominal cramps is due to the undigested food. Undigested food being fermented by your large gut bacteria. Now this is something that happens even in small intestinal diarrhea, because in small intestinal diarrhea, you're getting osmotic diarrhea, wherein at the end of the day, digestion is not occurring properly, malabsorption is there. So large volumes of carbohydrates are passing into the large intestine, where colonic bacteria, they are present over there, and what they will do is they will ferment the nutrients in my undigested and unabsorbed carbs, and they will, we have already seen this in osmotic diarrhea, what they will lead to flatulence, they will lead to gas formation, and they will also lead to abdominal discomfort, some abdominal cramps. But rigidity in my abdomen, or very strong abdominal pains, or blood and mucus and tenesmus, these things are large intestine, purely large intestine diarrhea. Okay, some abdominal cramps, some abdominal discomfort you might also get. Just like that, bloating also is something that you can get in small intestine and large intestine diarrhea. Okay, okay. Now, another thing, a few other not so important, but clinically relevant points as far as the differences are concerned is vomiting. What about vomiting? See, if you notice carefully, I'm only discussing the pertinent points as far as the clinical presentations are concerned. You often find patients with abdominal pain and vomiting and nausea, right? That is why we are discussing all these together. What about vomiting? Will vomiting be associated with the diarrhea? It can be. It can be in small intestinal diarrhea, but large intestinal diarrhea, pure large intestinal diarrhea, you won't see it. It's rare. Why is vomiting there? Because vomiting is mostly due to the toxins that have been formed by the bacteria or the microbes. Okay, so that is the thing. And how can we forget steatorrhea? Steatorrhea is definitely only here, never ever in large intestine. And how you find steatorrhea? Pale, bulky, frothy stools, okay, greasy looking stools, you'll suspect it, and then you will go for the 72-hour fecal fat excretion test, and you will find that the stool excretion is greater than 7 grams per day. That is the diagnostic quantitative test for steatorrhea. Qualitative test was Sudan 3 dye. We know all this from our discussion. So this brings us to the end of small intestinal diarrhea and large intestinal diarrhea, and we have seen that mostly small intestinal diarrhea is being caused by osmotic, that is malabsorption, or by secretory counterpart, which is due to the preformed toxins by enterotoxin E. coli or Vibrio cholerae. These organisms that are present, we'll talk about it in a little bit more detail in a later video. Don't worry about it. If you're not getting what these organisms are, or if you have some idea but you are still confused as to what organism is causing what kind of a diarrhea, what correlation is there, we'll explain it in some detail in a later video. Don't worry about that. But the full context of this will be explained only and only when you study microbiology, because this is an entirely microbiological domain. From the clinical perspective, we are leaning more into that. We are leaning more into the clinical perspective over here because we are looking at this from a clinical medicine kind of a perspective. But microbiology is going hand in hand with all of this. So infective organisms, invasive organisms like Shigella. Then we also have some other organisms like we had enterotoxigenic E. coli over here. We also have non-typhoid Salmonella. Let me actually write it properly over here. Okay, I should have written it right then. So Shigella, then some other examples. Non-typhoid Salmonella. We know that Salmonella typhi causes typhoid, enteric fever. And that is another very, very important thing. We'll see that Salmonella typhi, typhoid actually, it's an invasive thing, but mostly does not cause diarrhea as such. It will cause abdominal pain, but diarrhea is a rare presentation in typhoid, enteric fever. It will cause like a very excruciating kind of an abdominal pain. That is true. But diarrhea as such is caused more by non-typhoid Salmonella, which is the large intestinal variety, large intestinal diarrhea, and Shigella. And we'll also see that Campylobacter can also cause Campylobacter. Okay, whereas these are enterotoxigenic E. coli, Vibrio cholerae, and I have already said that viral things, the viral etiology is much more common in case of small intestinal watery diarrhea, secretory diarrhea, right? We have seen that norovirus, rotavirus, these viruses, they also cause this. So now, if I have to sum up the clinical approach to diarrhea, what is that? Okay, this is very, very high yield. So listen very closely. What will be my clinical approach to something like diarrhea? Okay. The first thing that you're going to look at is the duration. That is it. How long are the symptoms of the patient persisting for? If they are for less than 2 weeks, I will be pretty confident that this is an infective etiology. Because less than 2 weeks means that this is an acute presentation. And acute presentation for something that has been a problem for over a decade, for example, a tumor, does that make sense? For example, I'm just exemplifying over here. Suppose the etiology is a VIPoma. It's a tumor of the GI tract. Due to that, some kind of a secretory part is there, and that is actually leading to my diarrhea. Do you think that the presentation will be as acute as less than 2 weeks? Suddenly the patient will get symptoms? Obviously not. Suppose the patient has some kind of a malabsorption syndrome. Do you think that the presentation will be acute? Whenever in medicine you have an acute setting of something, think that it might be an infective cause. Okay? Obviously, I'm not talking about acute myocardial infarction. Acute myocardial infarction does not have an infective cause. Obviously, that's common sense. But anything which can be caused by an infection, like diarrhea. So I'll think about an infection. Now, an infection can be what? An infection can be in the small intestine, or it can be in the large intestine. And we have just spent the last 10 minutes deciding whether it's a small intestinal diarrhea or whether it's a large intestinal diarrhea based on the symptoms that the patient presents us with. Small intestinal means it will be large volume, watery stools. There will be no abdominal pain as such. Frequency will be less. Tenesmus, blood and mucus won't be present. Tenesmus will be not present. All that, right? So if small intestinal is the cause, then viral etiology is something that I'll be mostly suspecting. It can also be something like a bacterial etiology, like enterotoxigenic E. coli. It can be cholera, Vibrio cholerae. And if this is the case, then mostly these are self-limiting. Which is why most diarrhea, and this is the most common presentation as well, most people that present with diarrhea have a problem for like 3 or 4 days, and then it goes away. No problem as such. This is the most common presentation of diarrhea. Done. It is self-limiting. It is a nuisance syndrome. Large intestine, on the other hand, you will get like fever, pain abdomen, blood, mucus, all that. This is caused by invasive organisms. Remember, we are only talking about acute infections. Large intestinal diarrhea can also be due to what? It can also be due to inflammation. Yes. Small intestinal diarrhea can also be due to malabsorption, osmotic diarrhea. We have seen this. But will it be an acute setting? No. It will be a chronic setting. We'll see it to that. So, large intestine, invasive organism. Like I've already said this. It can be Shigella. It can be something like non-typhoid Salmonella, or it can also be something like Campylobacter. Okay, sure, no problem. So this is the acute setting. Now, just like that, if the symptoms have been persisting for more than 4 weeks, it is a chronic setting. We know this. If it is chronic, then again you will see whether the problem is in the small intestine or is it the large intestine. If the problem is in the small intestine, how will you decide if it's in the small intestine? Again, the symptoms will tell you. Watery diarrhea, frequency is less, abdominal pain is not there, blood and mucus is not there, large volumes, all that is pointing to a small intestine. If there is small intestine, in a chronic setting, it cannot be simply an infection. It will be something else, like osmotic diarrhea. Osmotic diarrhea. And we have already seen that osmotic diarrhea, how will you find out whether it's osmotic diarrhea or not? So I'll need to find out if it's malabsorption or not. So firstly, the stool osmotic gap will be increased. We have seen this. Stool osmotic gap is increased in this, and this will actually improve on fasting. Improve on fasting. And we have already seen as to why that is. Osmotic diarrhea is due to malabsorption. The fats in my, mostly due to fat malabsorption. The fat in my food is not getting absorbed properly. So the fats, what they'll do, calorie dense nutrient, it will draw in water from my tract, gastric tract, and this will rush towards my large intestine. It will move through the entire gut, and then it will be excreted as pale, greasy, bulky stools, which is called steatorrhea. Classical presentation of osmotic diarrhea. What is stool osmotic gap? We have already seen to this. It is the measured osmolality minus the calculated osmolality of the stool. Measured osmolality, will it be high? Yes, it will be high. Why? Because I have calorie dense, osmotically active fats in my stool, and I'm excreting a lot of fat. So osmotically dense stool. So the measured osmolality will be high minus the calculated osmolality, which will be normal. So the difference will be high. So the stool osmotic gap is high. This is all revision, by the way. So I'm hoping and praying that you're all getting this and not just zooming around. All this is not just zooming around your head. And we also know that since if we fast, no more fat in our food because we are not eating any food. So this all problem was due to fat being in my food, steatorrhea. So now no fat, or I'm not even eating anything. So my symptoms will improve. But my symptoms will not improve if this was either an infective etiology or if it was secretory diarrhea. We know that secretory diarrhea can be due to an infection as well, as we have seen over here, these things. But secretory diarrhea can also be due to, like I've said, a tumor, VIPoma. Okay. Now, if it is a large intestine and it is chronic, then again, it's not an infection. What can it be? It is inflammation. And what kind of inflammation? It is IBD, inflammatory bowel disease, or ulcerative colitis. This is the clinical approach to diarrhea. I hope all of this has been very, very clear to all of you. And with this, we come to the end of our first clinical module on diarrhea. In our next video, we'll be seeing as to a little bit more detail of the malabsorption syndromes. Okay. So hopefully this video on diarrhea has been somewhat essential for all of you. And I hope to see all of you very, very soon in my next video. Thank you.